Hello, my name is Olabisi Oyaripa. I'm here with Amanisi today and we're going to do the examination of the wrist joint. Amanisi is a 42-year-old. He is right-handed. His occupation is building furniture and interior decoration. He does a lot of driving, a lot of handling of heavy lifting. He also does a lot of manual work with his hands, with a variety of motion and combined motion. He noticed the pain about 2 months ago when he was carrying something heavy, and he says the pain was around the styloid process, and it's around the styloid process of the right hand, and he did not notice any swelling, and when he dropped the heavy item, the pain stopped. Now, the pain was not associated with any form of trauma. It was not associated with any clicking or abnormal sounds. There was no swelling, there was no erythema. It was just insidious at the onset of the pain, and the pain is aggravated with number of factors, with heavy lifting, especially when he lifts with supination and radial deviation. When he rests his chin on his hands, like, can you demonstrate that please? He feels pain when he does this movement, and also feels pain when he's doing a lot of rotatory movement while building furniture. Now, on general review of his health, his personal health and his personal medical history and his family medical history, where there was no significant finding in it, and there was no significant finding in any other parts on review of his systems. Now, with the symptoms of the pain on his right hand, he described the pain as an achy pain, intermittent, only aggravated with the aggravating factors that we've mentioned, and relieved with rest. He says when he modifies the activity that he's doing, that the pain stops immediately. It does not continue aching or throb. It just stops once he drops the heavy item, or he moves his hand away from, or he modifies the movement. So for him, he's been coping with the pain with rest and by staying away from the aggravating position. So I would say that the pain is posture and work related. Now, he says he feels pain in his right hand. When he came into the clinic, there was no sign of atrophy. There was no swelling. Compared with the other hand, there was no swelling on the palmar and also on the dorsal. There was no sign of swelling. There was no erythema. There was no sign of atrophy. The alignment of his forearms to his arms to his forearms to his hand was in good alignment. He also found that the site of the pain, when he feels the pain around there, once he moves the hand into the neutral position, the pain stops. Now, on the visual analog scale, he gave the pain a number 7, and he says the 7 has been constant since 2 months ago up till now. The pain has been constant since 2 months ago to now on the number 7. And he also reported that he has never taken any medication for the pain. All he does is just rest and activity modification. Going into examination on active motion of the wrist. If he goes into flexion as far as you can, he feels pain on active motion. Go into extension as far as you can. It feels no pain on active extension. Now go into radial deviation as far as you can. It feels no pain on radial deviation, nor does it feel any pain on ulnar deviation. This range of motion is within the normal range as compared to the other side. The motion is within normal range of motion. And on examination of his palm, the transverse arc, the longitudinal arc, the metacarpal arc, and also the oblique arcs are normal. The palm, as you can see, is pink. There's no sign of anemia, and with perfusion, you can see good perfusion in a few seconds all over. And examining his nails, you see that his nail bed is normal. There's no ecchymosis, no clubbing of his nails. There's no nail spooning. So we ruled out all red flags. There's absence of any red flags. So also looking at the hypothenar and the thenar eminence, you see that it's normal. And also you see that all the arcs are normal. One more thing that I did was the anatomical snuff box. On palpation of the anatomical snuff box, there is no tenderness, nor there is any pain in the anatomical snuff box. This shows that this rules out scaphoid fracture, which is indicated when palpating by tenderness in the anatomical snuff box. The scaphoid fracture was also ruled out with the X-ray that was normal. And also when we did the provocative test of the scaphoid, it didn't feel any pain, it was negative. When we did the provocative test of the trapezium, was negative, and also the scapholunate. There's no excess gaping or movements, which shows that there's no scapholunate instability. Now, active motion showed that there was pain in flexion, in active flexion, but all the others were negative. Now I'm going to do the motion passive. Now I'm going to take the hand into passive flexion. You can see in his face that is already apprehensive. It's painful when I go into passive flexion. In passive extension, there is no pain. When I go into passive radial deviation, there is no pain. When I go into passive ulnar deviation, there is no pain. There is no pain on supination, neither is there any pain on passive pronation. However, when I do the combined movement of flexion, of extension, and then I take it into, if I go into extension and I take it into radial deviation, there is no pain. When I take it into ulnar deviation, there's no pain. However, if I take it into flexion, there's pain. So I'm going to release the slack a bit until there's no pain, so we don't get a false positive. And I'll take it into radial deviation. He feels pain on this movement, this combined movement, but it doesn't feel pain when I go into flexion and ulnar deviation. There is no pain. But when I go into the combined movement of flexion and radial deviation, there is pain. Now, this could be a number of reasons for this. It could be the ligaments that is causing this. It could be the tendons that is inflamed. It could be a number of things. However, when we did the pain provocative test, it was negative, so there was no fracture. The X-ray confirmed that. When I did the ligamentous test, they were all negative. All the stress tests were negative. All the tests were negative. However, when I did the phalanx test, the phalanx test is a test that you normally use for carpal tunnel syndrome. However, when he did it, he felt pain, not numbness and tingling. So I'm going to do that now. He did the phalanx test. I want you to go this way first. Good. Now, let your elbows straight on the table. Good. When he does this, he feels pain around the radial styloid. And when he goes into the reverse, 90 degrees, good. He also feels pain here. It is not numbness or tingling, so it's not positive for carpal tunnel syndrome, but it reproduces the pain around the styloid, the radial styloid. Now, what I'm thinking right now is from the differential diagnosis, I've limited it down to tenosynovitis of the abductor pollicis longus and the extensor pollicis brevis. Now, I'm going to confirm all this using one more test. That's the Finkelstein's test, which will be positive if it is tenosynovitis. So I'm going to take this thumb into flexion, and then I'm going to do ulnar deviation, putting stress on those tendons. Now, I'm going to go. Now, when I do that, he feels pain. You can see on the apprehension of your face, he feels pain there. So that is the final test I'm going to do. That confirms that he has tenosynovitis of the APL and EPL. Now, for this kind of situation, what I'll start with is price MM. That is protection, ice therapy, compression, elevation, and a bit of manual therapy. I'm going to start with that, and I'm going to do the ice for 20 to 30 minutes. And continue subsequently to the cryotherapy. I'm going to use non-steroidal anti-inflammatory gel on the area to reduce inflammation. I'll also use some physiotherapy modalities like ultrasound using the pulsed mode to relieve pain, reduce inflammation, and prevent any adhesions in that area. And then I'm going to use splinting of the thumb to take the stress off the tendons, because it's an inflammation of the tendon sheaths that's causing the pain. So I'm going to splint the thumb in relation to the rest of the fingers to prevent him from taking putting pressure, putting unnecessary tension on the tendons. So I'm going to split his finger, especially while he's walking. I'll give him a dynamic split I can use while he's walking so it doesn't affect him. And then I'm also going to give him a lot of modification of activities, any activities that